Streams live. Hello, everyone. So this is Kim's Cuddles coming live today with a parent awareness event on neural tube defects. As many of you may be aware, March 3rd is observed as the Birth Defects Awareness Month, Awareness Day. Now, when you see nations where neonatal mortality rate and under 5 mortality rate is coming down, which is happening with advances in neonatal intensive care, pediatric intensive care, immunization, and better breastfeeding, we always find that the proportion of mortality, both among newborns and among under 5 children, contributed by birth defects is always on the rise. So in the most advanced of countries, birth defects can contribute to up to 20% of neonatal deaths. And today in India, as we stand with a neonatal mortality rate of 20 per 1,000, which means 20 babies out of 1,000 live-born babies may die before they reach the first 28 days from birth, and an under 5 mortality rate of 25 per 1,000. The same thing until their 5th birthday. So 25 out of 1,000 children may die before their 5th birthday. So these are the statistics, and we are definitely at the stage where we need to really address preventive strategies, effective screening, early detection, and effective treatment of birth defects in order to improve child survival, in order to improve neonatal survival, and in order to reduce morbidities created by this important group of challenge. So today, to discuss one unique subset of birth defects, the neural tube defects, we have with us Dr. Savitr Sastri, who is our consultant neurosurgeon, minimally invasive surgeon. I'm Dr. Aparna, Chief Neonatologist at Kim's Cuddles, Kondapur. We are joined by Dr. Revant from our team, who is going to discuss some questions so that we can take this discussion forward. We would love to hear from all of you, and if you have questions, please do share with us over the chat box so that we can take them as we move. So let's begin this discussion with a few commonly asked questions on neural tube defects. Over to Dr. Revant.
Thank you, ma'am. Sir, what is spina bifida?
So when the fetus is developing, when the embryo becomes the fetus inside the uterus, the brain and the spine develop from the skin, where the skin curves down inside and forms a tube. Now, spina bifida occurs when the tube does not form completely, and at various points in this tube, it may be an incomplete formation of the tube, with structures of the brain then being exposed to either covered by a thin layer of skin or just exposed to the air. Now, starting from the head down to the spine, in its worst form, spina bifida can present with something called anencephaly, which is not compatible with life. And this is where the entire skull and brain do not form completely. And in its mildest form, it's called spina bifida occulta, where we don't see any lumps on the spine of the child, but sometimes there may be a patch of hair or a small dimple around the spine that may suggest that there may be a very mild form of spina bifida. So anywhere in the middle, we have meningomyelocele or meningocele, and these are basically exposed. Meningomyelocele are exposed spinal cord tissue, which may be covered by a thin membrane, and meningocele only have the coverings of the brain and the spine under the skin. So these are the various types of spina bifida that we may see.
Ma'am, how do neural tube defects present? What are the common symptoms, ma'am?
So as Dr. Savitr just told us, one of the common ways that we identify a neural tube defect is by the physical appearance of an obvious defect in the baby's spine, which may be covered with intact skin, or sometimes you may also see that the skin covering or the membranous covering is missing, and there may be leakage of the cerebrospinal fluid from this defect. So based on the location, you may see this over the lower part of the baby's spine, which is referred to as a lumbosacral part of the spine. Sometimes we may see defects higher up. There could be an encephalocele, which can be seen over the head, where there is a defect that is protruding from the baby's skull. In more severe types of defects, often referred to as craniorachis, we may see this defect spanning over the entire baby's spine, and there could be significant area of skin defect that might be seen. Now, when it comes to the other manifestations or signs and symptoms created by these defects, the child or the newborn baby may have weakness involving the lower limbs. The child may have difficulty in moving the legs. There could be sensory defects sometimes, which of course is difficult for a young baby to report, but there may be difficulty in perceiving pain, perceiving touch sensation, which may be detected as the child grows up. Sometimes there can be subtle problems in walking, what we call as disturbances in gait, which can be only identified when the child becomes further bigger and starts walking. And we also see a proportion of these defects contributing to disturbances in bladder and bowel function. So there can be difficulty in passing urine, in passing stool. There can be a wide open anal opening, what we call as absence of the anal wing. So some of these children, when they grow up, may require assistance for emptying the bladder, wherein a small pipe might have to be passed through the urethra every time the child wants to void, because spontaneous emptying of the bladder might not happen. So there can be various ways these neural tube defects can present, and in the mildest form, which is called as spina bifida occulta, the baby actually may not have an obvious defect that is perceptible from when we examine the baby's back. The defect in the fusion of the backside of the bone underlying the spinal cord might be so subtle, it may not be accompanied by an obvious swelling over the back, but we may only have to suspect this based on some other small changes over the skin that is underlying the back. So there may be changes in the pigmentation, there could be abnormal deposition of fat, which is called as a lipoma, or there could be a hemangioma, which is prominence of the blood vessels overlying the defect. So there could also be an abnormal sacral dimple or a small hole or an opening that is seen over the back of the baby. So it can present with absolutely no symptoms like we see with spina bifida occulta, or there may be more severe types of neural tube defects which may present with the obvious swelling and difficulties in walking sensation and bladder bowel function.
Sir, do children with spina bifida also have a condition called hydrocephalus?
Yes, there is a subset of children with meningoceles or meningomyloceles, and usually just these two, and not the less severe forms, which may be associated with increased water within the brain, which is called hydrocephalus. In addition to that, they may also have a problem near the base of the brain, where the brain joins the spine, called a Chiari type malformation. So we know that spina bifida is associated with hydrocephalus and with Chiari malformations, and which is why when we do investigate these children, we usually get an MRI of the entire brain and spine, and not just the part that's very obviously abnormal. And it's important to rule out these other associated anomalies, because they would either need follow-up or would need treatment even before the spina bifida is treated.
This entity of occult neural tube defect.
So we discussed this. So occult neural tube defects are a group of problems where there may not be an obvious swelling over the spine that happens with the more obvious variety of spina bifida, and we may only have to suspect this based on some skin anomalies. But these also may present with defect in the fusion of the vertebral column or the backside of the backbone of the baby. So these will need a high index of suspicion and appropriate imaging, usually in the form of an ultrasound initially, and if needed, an MRI of the spine might be required for picking these conditions.
Ma'am, what are the causes of spina bifida?
So unfortunately, we've not been able to identify one reason for the occurrence of spina bifida. Some of the common reasons are deficiency of folic acid, especially during pregnancy. So this is the reason why, as a primary preventive strategy, every woman who's planning to get pregnant is ideally advised to consume 400 micrograms of folic acid. So sometimes it may be possible that even if folic acid supplementation has been adequate, due to some genetic factors in the metabolism of folic acid, a mother may be more predisposed to deliver a baby with a spinal defect, a neural tube defect. So apart from folic acid deficiency, which is a common and treatable and preventable nutritional deficiency which predisposes to neural tube defects, there could be some genetic factors in the metabolism of folic acid which can also predispose to neural tube defects. Mothers with uncontrolled diabetes are also found to have many times higher risk of having a baby with neural tube defects. So all these factors must be borne in mind while during the antenatal follow-up phase, because there are some ways to identify neural tube defects early, and this can make significant impact on the subsequent management of the baby. Another important category is mothers who are taking anti-seizure medications. They may also develop higher chance of folic acid deficiency and hence fetuses with neural tube defects.
Is there any way to know fetus has spina bifida?
So with advances in antenatal ultrasounds, yes, it is very much possible to identify the obvious types of spina bifida in I would say in many of the cases. It may not be possible in 100% of fetuses with spina bifida. But with advances in ultrasound, with 3-dimensional, 4-dimensional ultrasounds that are now being performed for pregnant mothers, it is possible to identify particularly the more severe and lethal forms of neural tube defects from as early as 11 weeks of pregnancy. Especially anencephaly can be identified quite early in pregnancy. There are also some biochemical markers which are performed usually between 16 to 18 weeks of pregnancy. One important biochemical marker is the serum alpha-fetoprotein, which is a blood test that is performed from the mother's blood. This is usually a part of what we say as triple screen or quadruple screen, where it is accompanied by some other markers like beta-HCG and unconjugated estriol and inhibin. So the levels of serum AFP may go up in the mother's blood if the baby has neural tube defects. Of course, this is not very specific, and it may also be increased in some other conditions. So blood test performed at the right time in combination with antenatal ultrasounds performed by a fetal medicine expert, and in cases where there is a suspicious neural tube defect, the use of fetal MRI. All these modalities can help us in early detection of these defects. And may I request Dr. Savitr to speak a little bit on fetal MRI?
So the fetal MRI is a relatively more recent investigation that we use in cases where we suspect meningomyelocele. Outside of the ultrasound, the next safest scan that can be done in pregnant women, even for the fetus itself, is an MRI, and there's absolutely no fear for it. The MRI sequences are also extremely rapid, so they correct for movement of the child during the scan. But primarily, the screening test is an ultrasound, and we resort to the next levels of either looking for metabolites, like Dr. Aparna said, or a fetal MRI if, for whatever reason, the ultrasound is only suspicious, but not definitely does not definitely detect the anomaly. So fetal MRI would be second line, but only if the ultrasound is kind of not clear.
Sir, how spina bifida treated during pregnancy?
So, sorry. There was a study conducted almost 10 or 15 years ago called the MOM study, which was Management of Meningomyelocele Study. And the study was conducted in 3 centers in America where they performed fetal surgery at the age of about 28 to 30 weeks, where they did what's effectively a C-section, retrieved the baby, and while the baby was still connected to the placenta, they went ahead and repaired the meningomyelocele, put the baby back in, closed up the uterus, and these children were then delivered by elective C-section closer to term. They found that there were certain, and they compared this with children who were treated immediately after they were born, and they found that there is reduction in the need for, in the incidence of hydrocephalus in these children, so who were treated in utero. There was a small improvement in neurological function, but these were the 2 things that they found was definitely different between treating them in utero versus treating them outside. That being said, fetal surgery is extremely complicated and has a definite chance of losing the baby after the surgery. And the chance is small, but it's real. So it's done in very, very few extremely specialized centers which can handle these surgeries. Uh, but yeah, it can be done during pregnancy.
Ma'am, how spina bifida can be managed after birth?
Right. So if a baby is delivered and has an obvious neural tube defect, then the first, the first step would be to evaluate the baby thoroughly, which would include, in addition to essential, blood investigations to understand if the baby has appropriate hemoglobin and coagulation parameters in case the baby needs immediate surgery. An important part of the evaluation will include neuroimaging, as discussed by Dr. Savitr, because a proportion of these babies can have increased swelling of the ventricles, which contain water within the brain. So this is a condition called hydrocephalus, and if hydrocephalus is present already when the baby is born, then the treatment options are going to be different. Now, while evaluating the baby, we also should understand that some of these babies may have Arnold-Chiari-2 malformation, which is a defect in the base of the brain. So this is an important consideration while we start with the evaluation. As the treating pediatrician, one also needs to understand if the spina bifida has already caused some degree of neurological deficits in the baby's body. This is possible by performing a thorough neurological examination to see the muscle tone of the lower part of the baby's body. So one needs to assess if the baby is moving the limbs against gravity, is the baby able to pass urine without retention of urine, without bladder retention, is the baby able to pass stools appropriately. So how is the muscle tone? Tone is the resting state of contraction of the muscles. So all these things are evaluated while the baby is prepared for surgery, if at all the baby satisfies criteria for immediate surgery. Of course, the timing of surgery depends upon whether the baby's covering over the neural tube defect is intact versus not. So in case of the skin or membranous covering over the neural tube defect not being present, or if there is leakage of cerebrospinal fluid, then this becomes an indication for emergency surgery. So I'll let Dr. Savit discuss with you about the timing and the type of surgical management.
Yeah, like Dr. Aparna said, if there is leakage of fluid from the meningocele, from the anomaly, then that becomes an emergency, because if fluid can leak out, then bacteria can go inside. The next thing you can be dealing with is a newborn baby with brain infection, and that's extremely hard to manage. So for children for babies who present with a swelling in the back, which looks red, which looks angry, which is leaking fluid, we usually consider emergent surgery within the first 24 hours of birth. Today, thankfully, we have excellent NICUs, and we have a backup of an entire team that can handle these children who are extremely delicate and require a lot of intensive care following surgery. So the priority of surgery in these situations is to stop the leak, is to get the coverings of the spinal cord back in place, and to close the defect with normal skin. And that sometimes involves a little bit of plastic surgery where we rotate skin flaps and close up the skin. But the important thing is in these situations is these children are, 2 kilograms, 2.5 kilograms, sometimes even less. And we can't lose more than 15 to 20 milliliters of blood. So from that respect, I think what's really important is the technical delicacy with which this kind of surgery needs to be done, the delicateness, sorry, that this kind of surgery needs to be done, and the backup that we have of the entire neonatology and the NICU team to be able to take care of these children after surgery. If there is no leak and the coverings of the meningocele or the meningomyelocele are intact, then we have the option of waiting a little while till the child gains enough weight to make the surgery a lot safer. We usually wait for about 3 months, or about 10 to 12 kilograms of body weight, where we're able to go ahead and do a surgery with a lot more a lot more safety than having to do an urgent surgery. At the same time, the initial evaluation includes an MRI of the brain and the junction of the brain and the spine and the entire spine. And if there is hydrocephalus, that's an additional thing that we need to treat. First, if there's no leak in one, so the first thing that needs to be treated is the hydrocephalus, and following that, we go ahead and treat the meningocele. And the hydrocephalus is usually treated at this age with something called a ventriculoperitoneal shunt or a VP shunt, which is a tube that goes into the brain and runs under the skin into the abdomen, where excess fluid can just get drained into the child's body itself.
Sir, what are the other long-term issues that child who were treated for spina bifida can have, sir?
So, children who are born paralyzed with no strength in their lower limbs usually do not recover that strength because this damage has happened to exposed spinal tissue, and exposure of spinal tissue to amniotic fluid inside the uterus is considered to be one of the factors that causes neural damage. So children who are born paralyzed usually, despite significant physiotherapy and supportive care, don't completely recover normal locomotion, normal power in their lower limbs. Their bowels usually somehow manage to adjust themselves over time, and they will require some assistance from the urologists for urological rehabilitation, either in the form of intermittent catheterization or a permanent catheter to prevent retention of urine. Now, retention of urine is again a problem because it can cause damage to the kidneys if the urine is not passed out of the body. The other issues that these children can have is something called tethering, where the spinal cord gets attached at the point where there's a defect. And as the child grows and its spine elongates, the spinal cord and the nerves may get stretched, and they can present with weakness of the feet, of the legs. They can present with, again, urinary disturbances. So children of spina bifida who've been treated need to be followed up at least every year, if not earlier, and if not more frequently. And we check their power in the lower limbs. We do a urodynamic study to see if their urine flow is normal. We repeat imaging every 2 or 3 years to make sure there's no fresh tethering that can happen. But what is really, really important is that if the children have hydrocephalus, which is treated, or don't have hydrocephalus at all, their intellectual development is normal. Right, so that is something that we constantly keep in mind when we are treating children with spina bifida, that their brains are not damaged. It's only, and sometimes, even their spines are not damaged. It's only a little swelling that we see, and it's a cosmetic surgery even, just to get rid of the swelling and close up the skin. But it's important to know that these children are intellectually normal and can lead functional lives down the line.
Ma'am, can spina bifida can be prevented?
So as we discussed, yes, to a great extent, spina bifida can be prevented with appropriate supplementation of folic acid. So there are two ways or two kind of preventive strategies that we speak about here. One is prevention for every mother. Say she may be absolutely low risk mother for having a baby with neural tube defect, like a first time pregnant mother who has no family history of a baby with neural tube defects. In such mothers, it is recommended that a dose of 400 micrograms or 0.4 milligrams of folic acid be started in them, not just from the time that they learn that they are pregnant, but well before the point of conception. So the ideal time to start this folic acid would be something like 1 month before conception, and this is to be continued until 3 months after conception. So essentially during the first trimester from around the time of conception. So since a majority of pregnancies in a large country like ours are essentially unplanned pregnancies, it may be advisable that married couples consider taking folic acid. I mean, the female partner considers taking folic acid through this phase while the couple might be planning pregnancy, because they may not really know when she may become pregnant. So this is a very, very important message that everyone needs to remember. In some countries, folic acid has also been a part of fortification of wheat flour or cereal, so that it reaches to the vast majority of pre-pregnant mothers there who may get pregnant over the next few weeks. So this is because the critical phase for the development of the neural tube is between the time from starting from embryogenesis to around 28 days from embryogenesis. So most mothers, by the time they realize that they are pregnant, would be around 6 to 7 weeks pregnant, by that time, starting folic acid might effectively be useless. So it's important to remember this critical time window for starting folic acid. Now, in case there has been a previous baby with neural tube defect, or if there has been a family history of delivering babies with neural tube defects where either one or both the parents may carry the genetic mutation that can predispose to neural tube defects, or if, say, the mother is an established a case of the folic acid metabolic gene mutation, which may explain a higher predisposition to neural tube defects, or if she is on anti-epileptic drugs, then the dose of folic acid that is recommended is 10 times higher. So the same time window folic acid is recommended, but in this case, the dose that is recommended is almost 4,000 micrograms or 4 milligrams, started again from 1 month prior conception to until 3 months after conception. So it has been seen that folic acid supplementation not only prevents the risk of neural tube defects by close to around 70%, but also is associated with a lesser chance of some other birth defects, particularly anorectal malformations, problems in the formation of the anal opening and the rectum of the baby, and some types of even cardiac defects. So this is a very, very useful public health strategy that can help us largely in prevention of these defects.
Sir, what will be the future of these kids?
Like I did mention, if they're unfortunately born with weakness of the lower limbs, then that usually doesn't get better. Then we look at urological rehabilitation, making sure that they don't have kidney damage because they're retaining urine. But intellectually, these kids are fine. And earlier on in the past, we didn't have the kind of sophisticated monitoring machinery that we use during surgery today, that we're able to identify even nerves as small as they would be in a newborn. So the risks of surgery are really, really low if the child has a fairly decent weight at the time of surgery. But I think what's really, really important is, one, that these children are intellectually normal. Two, they will require frequent follow-up. It's not like we do a surgery for a meningocele and the child is 3 months old and that's it. We will have to follow up. Congenital defects often have a way of, causing issues later on in life, especially during growth spurts. So when the child grows initially in the first 6 months, and then during adolescence and early adulthood, these are the times that fresh problems may crop up, and it's important to constantly follow up these children with at least clinical examinations and detailed history, if not imaging as well. But a lot of them do lead completely normal lives. They just have to keep coming to the hospital every year or so.
I find some messages in the chat box, and maybe let's take them up one by one. So thank you, Dr. Yoga Nagendra, for joining. And he has asked, when do you advise to continue or discontinue pregnancy if detected in the mother's womb? Okay. So, as discussed, the prognosis or outcome of neural tube defects can be quite variable. There could be some very severe and lethal forms of neural tube defects, like the anencephaly, where a baby's cranial vault or the covering over the baby's brain is completely absent. This condition is completely incompatible with normal life, or for that matter, with life at all. We may also see some other severe types like the rachis, which involves the entire spine. Now, in most other types of neural tube defects, there could be some morbidity, some degree of neurological involvement. There could be some degree of bladder, bowel involvement. But as Dr. Savitr has been telling us repeatedly, most of these children, when identified early, apart from those candidates who may be amenable for fetal surgery, most would fall under the category of postnatal surgery, and the timing would depend upon the presence or absence of intact skin. So, considering all these factors, one needs to have a discussion with the family involving the pediatrician or neonatologist, the neurosurgeon, the pediatric neurologist. Holistic discussion needs to be had with the family. Informed decisions can be taken by the family after they go through everything that comes with the neural tube defect, and there cannot be one clear-cut decision as to whether one should continue or one should discontinue the pregnancy. So in the more severe defects, of course, as clinicians, it's our duty to inform the family that the baby is going to have significant morbidity. In the rest of the spectrum, the decision needs to be individualized based on all the factors, including the presence or absence of associated cranial defects, the presence or absence of other organ involvement, the presence or absence of associated Arnold, Chiari, or hydrocephalus. So I'll request Dr. Savitr to chip in.
Yeah, I think if it is a major open spina bifida that's detected fairly early, and nowadays with improving prenatal diagnostics, we are able to detect them, then especially if they're not compatible with life, the advice would be to consider discontinuing the pregnancy. A lot of the times we find that the defects that we see nowadays are occult defects. They are defects that are really, really small, which may not have been possible to pick them up by ultrasound. And these children usually, are absolutely normal and have a cosmetic issue more than anything else. So in those cases, obviously, we would advise postnatal surgery and just frequent follow-ups, and we would advise to continue. There is, like Dr. Aparna said, a gray zone in the middle, where it has to be an informed decision. All the pros and the cons have to be discussed with the family, because we're also limited by how advanced medical science is today. And hopefully in the future, we will have more effective diagnosis, which will only get better, and we will be able to give a better advice. But as of now, I think we have two sets where we would continue, we would not continue, and a gray zone in between where I think a detailed conversation with the family and respecting their decision would make sense.
The next question says, good afternoon, doctors. Are NTDs a vitamin deficiency disorder? Well, not really. You may not really call them a vitamin deficiency disorder. But yes, as we discussed, one of the important risk factors for neural tube defects consistently has been shown to be folic acid deficiency or abnormalities in the metabolism of folic acid. So at least this one vitamin seems to play an important role in the causation of neural tube defects. Would you like to take the next question? Could
these cases be caused by nitrates or bacteria in drinking water? Honestly, there is no evidence that either of these are true, and I'm sure there's bacteria in all the water that we drink, and nitrates as well. The only factor that we have found that predisposes to neural tube defects is a family history of neural tube defects, and we know that what we've been saying time and time again, folic acid, one of the B vitamins, is implicated in the causation of neural tube defects. So it's important to supplement folic acid. We really haven't found any evidence of anything else being a cause.
So Anila has also asked another question. When during pregnancy can I be tested to see if my baby has a neural tube defect? So as we discussed, an early ultrasound, generally after you get your pregnancy confirmed with a HCG or urine HCG test, your doctor would advise you to get an early ultrasound to confirm that the pregnancy is an intrauterine pregnancy, and to confirm the presence of the fetal cardiac activity, usually around 6 to 7 weeks. Following this, an early scan is generally recommended at around 10 to 11 weeks. This is generally for looking at the neck fold thickness, nuchal translucency, which is important to rule out some genetic chromosomal conditions like Down syndrome. If there is a very severe form of neural tube defect like anencephaly, this can be identified as early as this early scan, at the 10 to 11 week scan itself. Now, the other important time window to remember is, 16 to 18 weeks, when your obstetrician would advise you to undergo the biochemical serum testing, which is a blood test that you would undergo, which includes four important metabolites, and one of them is the serum alpha fetoprotein, or AFP. This is an important marker and is generally elevated or increased when the baby has neural tube defect, amongst other reasons that can increase the serum AFP. So this is part of either the triple screen or the quadruple screen, and this is something that is advised to all pregnant mothers between 16 to 18 weeks. Of course, later on, a more detailed anomaly scanning, which is also referred to as the TIFA scanning, which is targeted towards picking up various type of structural abnormalities in the baby, is generally performed at 18 to 20 weeks. So make sure this scan is performed by a qualified fetal medicine expert. I'm sure all obstetricians taking care of pregnant mothers would get this scan done at between 18 to 20 weeks. So this scan is essential for picking up the more minor or moderate types of neural tube defects. Generally can be seen here or maybe suspected here, but sometimes very minor defects may be seen a little later, or sometimes may not be seen at all during the antenatal scans, and we may only pick up when we see the baby after birth, where there may be a small tuft of hair, or there may be a skin color change over the baby's back, or there may be a small swelling because of deposition, accumulation of fat, or an abnormally located hole or a sacral dimple. Now, these smaller signs which indicate an occult or a hidden neural tube defect, this may be more difficult to see during pregnancy, and sometimes maybe for the first time seen only after the baby is born. So during pregnancy, I think the things to be remembered are the early pregnancy scan, which is called as the NT scan, the mid-trimester triple screening or quadruple screening, which is a blood test, and the fetal anomaly scan, which is generally performed between 18 to 20 weeks. So do not miss these few important screening tests during pregnancy. The next question.
We have two questions here is from Anna Maria. One is, of course, a tuft of hair. Could it be a sign? Yes, it could. And the prognosis of neural tube defects largely depends on how bad the defect is and what the status of the child is when we do intervene. Spina bifida meningomyelocele with exposure of spinal cord tissue to the open without significant coverings is known to have a slightly worse prognosis, because there is already damage of neural tissue. And what we know about damaged neural tissue is that recovery is not as good as any other tissue in the body, like bone or muscle or skin is able to recover, but neural tissue doesn't really recover that well. So for children with an open meningomyelocele with damaged neural tissue, it's a lifelong of rehab, of exercises, of preventing issues such as bed sores, preventing urinary tract infections, preventing retrograde kidney damage. So that way the prognosis is not great, but it's not impossible to achieve. For minor forms of neural tube defects like spina bifida occulta or just meningocele, that way those have fairly good prognosis. We've done multiple meningocele where the children have grown up to be absolutely fine. We see adolescents and young adults with spina bifida occulta that we're able to detect because of MRI, and then treat so they don't have future issues. The thing with neural tube defects is occult neural tube defects or hidden neural tube defects, where there just might be a tuft of hair or a small swelling. These children may just grow up to be absolutely functioning adults and may suddenly present with, say, back pain or urinary difficulties much later in life. So our current protocol is, if there's a suspicion of a neural tube defect, we go ahead and get an MRI, and we keep these children on follow-up, and then choose to intervene at the earliest sign of any issues. And like I said, surgery today with the kind of neuromonitoring that we have is absolutely safe, and a lot of these children do really well as they grow old.
All right. I think if there are no more questions, yeah, we have taken up that question as well, the question on tuft of hair. So let me thank you all for joining us on this live chat. We hope it was useful. And maybe we'll wind up with the message that as we see more and more a higher proportion of newborn NICU admissions or NICU morbidities now being increasingly due to birth defects, as we keep evolving our understanding on the more common conditions like low birth weight, prematurity, and neonatal infections. It's very, very important that we understand that there are a lot of things that we all can do collectively as a community to prevent these neural tube defects or birth defects, a lot of them in general, which we'll be discussing in the subsequent weeks as well. And there are things that we can do for early identification and for effective and early management of these conditions. I'll let Dr. Savitr also finish with a concluding message.
Yeah, I think with advances in prenatal diagnosis, we are now, and our understanding of the brain and the spine, we are now able to, and of course with the kind of neonatology backup and the NICU backup that we have, we're now able to do safe and effective surgeries for these children. And with that, the overall outcome of neural tube defects is far better than what it used to be 20, 25 years ago. So from my perspective, I think if surgery is definitely safe, and even for newborn babies, if it's absolutely required, and long-term care is something that we cannot ignore, and long-term follow-ups is something that we cannot ignore. But the outlook does seem a lot better than it used to.
Right. With that, we thank you all for joining us today, and please do join us for the upcoming chats, talks that we are organizing in the coming Tuesdays, every week, 1 to 1:30, to discuss some other important groups of birth defects like surgical anomalies, cardiac defects, and some aspects about the antenatal ultrasound screening. Thank you all for joining us.
Thank you.